All right, Dr. Sharma, you're live. Room 6, brand
All
new
right.
cath lab.
That's it. You started with a brand new cath lab, and I really welcome again our excellent discussion. I mean, I would say the mission or the theme or aim we had for the symposium is working out very good. Only thing is, I see less people in the front. I saw when I left, a lot of people in the back. They should come in the front and enjoy and take the advantage of all the live cases and so. So with that note, we show the case number 4 is a 78-year-old patient who had a cabbage before and then was presented to outside hospital with chest pain and had the REMA to the RCA or OM was occluded. And they worked on the native, the left main to OM or circumflex, which I am going to show, and try to open it. Let's go through beginning very quickly. And patient is on good medical therapy, good ejection fraction. This is the right coronary, and this is the bypass to the right, which is 2 grafts, very good. Then to the diagonal, very nice. Then there is a LEMA to LAD, which is good. And then the REMA to the OM is occluded, and this is where it is. One layer, what they did is, it was calcific, severe calcium. I had the angiogram from outside, severe calcium, and then they did a balloon and put a stent. They thought that they have expanded it. They put the stent here, as you can see, 3.5 millimeter, and then did not see the stent could not be expanded exactly in the center. So then they did IVL 4.0. Multiple dilatation of the IVL 4.0 could not expand. This is just about a few weeks ago. So patient has been now referred to me that what to do. So clearly that can we do a atherectomy, rotational atherectomy? So we felt that it's a good case of unexpanded stent, which you can use various techniques, starting with a laser, rotational atherectomy, a high pressure balloon or cutting balloon won't help in this situation. And then IVL already had been tried and they could not expand this. So IVL was done post-stenting, but not done the pre, but a lot of calcium there. Yeah. So anyway, we are here. Can we show the IVUS? We did the IVUS in this particular case.
Oh, you were able to pass an IVUS there. That's cool. Yeah. Okay.
IVUS there, yeah. Yeah, here. So we start. Play the IVUS from distal to the enlarged OM. There's a plaque there, which we know, moderate disease.
Just looks
And
like they don't even have all that disease covered.
Yeah.
At all.
Yep. So that is a separate. They did not cover the entire disease. Now, this is a distal part of the stent, which is okay, which we saw angiographically. If they see the calcium behind, there's still a lot of circular calcium, and this is where they have the totally unexpanded stent right there. The MLA, we found a 2.7. This is the proximal part, and then comes to the left main. So this is a case of the unexpanded stent. So
but also a lot of tissue proliferation inside of that stent, distally, which is interesting. Well, we have an amazing panel here. Point. We have a great panel here, and I'm going to go to Dr. O'Neill first and foremost. Welcome to New York. It's wonderful to have you here, Dr. O'Neill, William O'Neill, pioneer in our field. What you must see a lot of this type of stuff in all the years that you've been treating complex disease. An underexpanded stent in a in a calcific lesion. What's your approach?
The vessel lumen itself is actually relatively large. So for vessels that are sort of less than 2 millimeters, we try to actually burr out using rotational atherectomy to really kind of remove them. And I think it causes microfracture, so that allows expansion. I would be really curious in this setting whether or not a shockwave would actually work to try to
I can't hear fully.
It looks like it's something they did after they stented when they recognized that this was a issue, and it looks like they didn't get anywhere. Dr. Nicholson, what's your approach here? What would be your approach?
Yeah, thanks. I think you really have 2 choices in these scenarios. I think coring it out with a larger and larger rotabur would be one option, and then this is one of the places I think laser is very helpful with a 1.4 laser with max fluency, max frequency. Oftentimes you need to augment with contrast injections to get the cavitary kind of explosions that you need, but I find that to be very effective in these scenarios. All the treatments, if you did lithotripsy as well, And I'm curious what Dr. Sharma is going to do. I mean, all of them basically take the polymer off the stent. So you converted it to a bare metal stent. So I don't know what
before we go to Dr. Sharma, I just want to hear Dr. Colombo's approach to this. I know that you have treated this a lot. Dr. Colombo?
If you can afford the laser with contrast injection, is really nice. I assume lithotripsy was already used, and if they size the balloon correctly, I would not use it again if it was done correctly. Rotablation is a good possibility, but you need a big burr because the residual lumen is large. In Europe, the most practical is a very high pressure balloon.
Yeah, I've seen you do that.
We have balloons from Sys Medical, they go to 44 atmosphere.
Yeah, that's a little crazy.
What you need is to be precise and not to oversize, otherwise you have to go to the cover stent. But if it is a little bit undersized, you can go to 44 and most of the time you succeed.
Yeah, so we have a 50-50, I think, vote for laser and rotational atherectomy. I don't know. I don't really like that high pressure balloon. I get nervous, but I've seen you do it, Dr. Colombo. No. So what's your approach?
But remember that high pressure, that high pressure balloon, Roxana, that open NC is a double layer balloon, not available in America yet.
Yeah.
It's many places outside. There's used for that purpose. So let me just go through, knowing that we had other interesting case. So here, what we did is we had 8 French guide, and we did, this is IVUS which we showed, and then we used a 2.0 bar. So we are here now after the 2.0 bar, and this is a picture after 2.0 bar. And we are ready with a bigger bar as mentioned with a 2.15, because this case will require a bigger bar, and now we actually have the laser ready. Now question is, just to answer, why not laser? This patient, because we have success, this is case referred, and the referred basically for rotablation. But we have the laser clearly with the contrast laser will be the second choice in this particular case, or maybe for some people could be the first choice. So we had done a 2.0 bar. Now we are going with a 2.15 with my associate Parashram here, and we have 2 fellows, Twinkle and Jonathan. So all, and of course, rest of my cath lab staff, all ready to 2.15. Now, biggest question here will be that burr can get stuck, stored in this unexpanded stent. Very common. So have to be very, very careful. And if we cannot even go completely, which is okay, because you can just go inside and people ask, are you going to ablate the stent? You have to pull a little more harder. No? Okay. We have 2.15, you know the guide. Yeah, good. So we are okay. So why? So key is, that even you don't go completely. I know there are enough data now. They have seen that when you stent get ablated, because you see the microparticles in vitro, and otherwise also by the OCT after the rotablation. So you really create a cracks, or of course that part, the polymer is all gone, and so here with the 2.15 we'll be very careful. We want to make sure we do our 3 things back and forth here. At the level at the Y connector and a tap on the Dynaglide, which nothing happened. Now we are ready with a 2.15 bar.
How did the 2.0 burr go when you were going with the 2.0? Okay.
It was a little tough. It took us about 4 runs. Okay. Each run is about 20 seconds, but same. The key is careful, don't go. Now many times we have seen your burr does not traverse, but what it does, it heats up the metal. And then your subsequent balloon dilatation opens it up. And I want to keep it within the stent only, and 20-second ablation. Same. The CVT will tell us that it's more than 20 seconds. We are looking at the blood pressure. Nurses automatically give neosynephrine. Once it goes down to less than 100 systolic pressure, here we need a little push. And blood, they should be showing the hemodynamics one side also. Yeah.
What's the RPM you're choosing for these?
Yeah, 150. Right now, 150. If we need to go to further, we'll go further.
Okay,
but
so you start
our goal is that if you 8 times, 150. Most of our procedures are done with a 150. You know the Rota Pro.
You just went through.
Yeah. The Rota Pro. I actually had a lot to do design. So now, when you start your rotablation, you have actually you start with 155. So you can increase or decrease, but company makes it comes as a marketed with a 155 speed, which can, as I said, increase or decrease. So now we have done the rotablation. We'll put a wire side by side and go to the high pressure balloon. 4O. We have
4O.
Yeah. No, 8. We need short.
Oh, we have
Yeah. Right now we need a short. 3.5 or 4O. Remember, we cannot have the long balloon. You need to expand short balloon, knowing that we don't have an open NC, which Colombo spoke about, which can go to 40 atmosphere and so. Huh? 4O.
So you'll take a non-compliant short balloon trying to really
Short
push
balloon.
it out.
That area, yeah. Because remember, even you go and magnify. So if you see, it was just that area. Now actually you see a little bit of expansion, although people say maybe imagination, but most of the time I don't think that the rotablation ablate the stent. What it does basically is heat it up. Your subsequent balloon dilatation will then expand. Now we are 408 NC ready. I am still going to leave the rota wire just to get that extra mileage. And if not, we have outside the laser ready because we are another case in the afternoon. We have an excimer laser case. Yeah. So if this is the case where if this fails.
So do you want us to go to the other room or you want us to watch this? I'd love to see how this expands.
No, but watch this. If it open, yeah, exactly. Once it is open, then we're just going to re-stent it because it's a single layer. If it would have been double layer, then we do IVBT, but this is a single layer. We are going to just re-stent it. And of course, we'll cover the distal moderate lesion also because we saw on the IVUS, lot of plaque.
Well, I mean, I'm hoping that in the case of an underexpanded stent that a re-stenting should do, or maybe even a good balloon dilatation, but I saw a lot of tissue inside of the stent. I think you require another stent.
Yeah, go up. No, but one, and of course, we have taken away all the coverings and we have to go slow. So no matter what you do, you get a 3O cutting balloon also, although in the stent, it is
I
not
think
going
a
to work
cutting
now,
balloon will be
but we'll
very
go slow.
I was going to ask him next, the cutting balloon.
Yeah, 3O cutting balloon.
Yeah, we are getting a 4.
22 atmosphere.
Yeah, right. So we are, and otherwise also your balloons, when this happens, you go slowly. Keep going.
1 second.
Negative, no.
Yeah.
Yeah, so did not. Moved out. 4O. You have 3O, give me 3O right now. And then bring a 4O also. Okay, then give a 4O. This is a big case. Yeah, go up again, slowly. So that vessel, what was the Kiski? What was the vessel size? 4O. Yeah, it's a very big vessel. No, didn't expand yet. Negative. We need to go a little proximal, which is here. Yeah, that's the advantage or disadvantage of the short balloon also. It slips.
Yep.
Keep going.
The watermelon seating is also the disadvantage of a shorter balloon, but it does give you that better direct pressure.
Negative. Yeah. So I think it's looking a little better. Let me just pull back here. Yeah. Good. And we'll do the IVUS run later also. Make sure IVUS is clean. I know we've asked about imaging and so, that's okay. Yes, a lot of IVUSs, we do it. We do it more as a part of the symposium. And I know that a lot of IVUS fanatics will do multiple IVUSs between various things, but that's okay. That's a different strategy. Negative. But as long as whatever it does, you get a good results. That's what it matters. You go again. I think we opened it up now. Yeah. I think it expanded now. 10, 12, 14, 16, 18, 20, 24.
I'm still not convinced that it's expanded. I still see a little dog boning effect there in the middle.
Yeah. Yep. Negative. But I think now, no matter what you do, you'll not be able to take away the complete dog bone as long as we can get a good lumen, about 6 millimeters square, and so post. But I think this definitely has opened up. We'll try to see negative. Let's take a picture and then we decide. That we have a 4O cutter open, Wolverine. This can come out anyway.
Yeah, I'd like to see the 4O cutter there.
Okay.
I still don't think you're fully expanded. What does everyone else think? You guys feel satisfied, or you
No,
want
no.
to see imaging?
Yeah.
And
See the picture.
No, it is not expanded. Yeah.
IVUS. Everybody wants to see the IVUS.
Yeah. Okay. But let's see first. If it opened up a little bit, then only go. Oh,
Yeah.
it definitely has opened up. Yeah. Yeah, good. Let's do a cutter and then we do IVUS and then you can go to other room. So let's become a simple. This is a case just to highlight.
No,
a
I think
case
you
of,
got it. But now you could see the distal lesion better. That needs to be covered now with the new stent.
Yeah. No. Yeah. But at least the stent has been expanded now and we are going to do 4O quickly and then do the IVUS and that is it. So you see the expansion. We know exactly what it is beforehand and now. Now question is to Colombo. I know he was very big on this using a cutting balloon. But question is, how will the cutting balloon work now when there is already a stent?
We have used
This is
cutting
20
balloon with a stent a lot. I think it's
Yeah, negative,
it gives more uniform force because the blade keep the expansion uniform and not uneven like a high pressure balloon. So the only thing when you go to 24, 25 atmosphere, you have to
we are 24.
downsize because the cutting balloon has some compliance. Otherwise, you break the vessel.
Yeah.
Dr. Sharma, when they do the shock wave in the other institution, what size of shock wave balloon they use? Do you know?
4O. They use a 4O balloon. They use a 4O balloon and they did whatever the 20, 30 pulses and so. But 4O. They used it with a 4O. Yeah. They did not do the laser, but they used the shock wave.
Yeah,
They did not have, the center did not have both laser as well as rota available. Okay.
Kwan, would
So let's,
your
we are
approach
ready
be
with-
different?
There is a trick. Maybe I should not mention. It's very off label, but in many places they don't have a rotablator burst bigger than 1.75. They don't carry.
Mm-hmm.
So if you have a very big situation like here, you go with the 1.5 balloon and you rotablate with a 1.5 balloon inflated.
Oh, lovely.
And believe it or not, the balloon will not break because it's soft. And the 1.5
Okay. Put the IVUS there, please.
balloon makes the rotablator bigger.
We see the IVUS. We see
Oh,
it looks a lot better, much better.
lot better. Yeah. Absolutely.
Yeah, I think you've expanded it, but I think distal to the stent, there's a lesion. I think now you're going to treat the whole vessel well, right?
Yeah, so I mean, clearly that to me, just let's take a picture and then we cover that entire area. It's a large vessel. Go.
So, I mean, this is still on.
We're still
Good.
on.
At least the stent has been expanded. Yeah.
Let's go.
A lot of disease we know. We put a long stent.
Did you hear that? Wonderful result. How did it work?
I think very by heating the metal, not by ablating, heating the metal. And if that's okay, Roxana, you are ready to go into
Yes,
a
we're ready to go. We know what you're going to do here. You're obviously going to treat the beautiful result. Thank you. Thank you so much.
Now
This is
single
a
stand across. Yeah.
difficult problem. Thank you.
I have Nitin Barman here and my two fellows, Mahi and then Gurpreet.
Hi, guys.
And then we have Pablo, who is a chief tech. Will, who is a nurse here in this room. Then I have Christy. You can see her. And then Arna, who is another tech. So as you see how we are able to do all these complex cases because these guys are well trained and they know exactly what to do. Just with my eyes and my finger movements, they know what they have to do. So case number 5 here is an 85-year-old male who actually presented to an outside hospital with non-QMI with a troponin up to 14. So multiple comorbidities, hypertension, hyperlipidemia, EF about 45%, history of heart failure. So he has had prior bypass surgery with right now the patent graft is only Lima. So if you see the angiogram, this is the right coronary artery. EF about 45%. EDP was normal.
24.
And
24.
24.
Lima to the LAD
They've
open.
written there.
Yeah.
Yeah. So, Cat said EF 45, but Echo said EF 25. So the only patent graft was Lima that was supplying the entire LED and retrograde to the diagonal. So this is the left main to circumflex, dominant circumflex, calcified, angulated.
Diffuse, yes.
Does it almost look like
disease?
it's totally occluded or with a very, very antegrade flow is really small and almost like a bridge collateral, no? What does everyone else think here on the anatomy? Kwan?
Some of the haze from that calcium.
Yeah.
Let me give you another view.
I think the CTO will have a lot of breaching collateral.
Okay, that's a better view. It shows the
And not like calcium, too,
99%
right? Calcium.
antegrade flow there.
Yeah, heavy calcium. Then you have OM1. You see the bypass that was attached.
Yeah.
Then OM2 or LPL, whatever you want to call. The
Huge
question is in
territory.
this kind of calcific angulated circumflex, what is the first wire of choice? And this is where I think the guide wire aid is going to tell us what is the first wire of choice. And let's ask the panel how we would wire this case.
Yeah, let's start with Dr. Freeman. Dr. Freeman, you see a lot of non-STEMIs. Here's a case.
Well,
what would be your first wire of choice?
Yeah, the complicated part with the tortuosity is also the excessive calcium in the area. So you want, I might start with support and something like a whisper wire to get down distally and then switch out. But I'm assuming you're going to plan to roto that or use some type of atherectomy device through that proximal circ area.
Yeah, does anyone question the use of impella here? Let's start with Bill Nicholson.
I think you've got a working limit to the LED, but you're going to rotoblade a large territory, and it's going to be a lot of rotoblading. You got a bad EF of 20-25% to start with. I think is a very, very reasonable choice.
Dr. Mehta? Can you speak into the mic because we can't hear you?
Probably a run-through wire, then exchange it for a rotor, probably starting with the 1.5 burr and expanding, I think, with the second burr.
Wow, I get scared with a 1.5 burr. I don't know. What do you all think? Like 1.25, 1.5? I don't know. It's very, very severe.
No, but I think let's go to wiring is very challenging in this case. That is, I think, the key in this.
We have your aid up there. It's showing us what we should be doing here. But Dr. O'Neill?
I think the most difficult part of this is getting the rotor wire down distally. I think that's going to be the biggest challenge.
Yeah.
You can wire
we can't.
Something, but actually getting the exchange is going to be quite.
We can't hear.
Yeah, Dr. O'Neill is saying that the most difficult and challenging part of this is getting your rotowire distal into exactly where you want to ablate. That's going to be difficult, even in the exchange, etc. So that's going to be really, really interesting to watch. So tell us, what's your plan, Dr. Kinney?
So our plan is I have a fine cross, and I'm going to start with the fielder. This is what we have actually mentioned also in the app, that you will start a case like this with a fielder. I mean, it is all depend. Everybody has to probably use a polymer jacketed wire to see if we can go through this angulated calcific vessel. And I just need to show you, this is how we did this case. So if you see here, fielder, same. What we say is twirling movements, and it's trying to go into the OM, which we knew. Now you pull back. We had a nice curve in the fielder. Then rotate, and you get into the distal circ to the LPL. Like we mentioned, the next challenging part is, can we get the fine cross? So this is exactly, you see that?
Yep.
That calcium and the angle, the fine cross would not go down. So what you essentially do is you twirl, rotate like you want to do with a corset. Exactly the same movements you can see here. Get your guide in. Guide has to be advanced. Guide is, see that, trying to come out. Keep the guide engaged and keep doing. And now it went through.
You got it.
Yeah,
Nice.
then we exchange it to the rotor wire. Now, question is the same. If the fine cross had gone easily, we would have used a 1.5 burr. Knowing that it was so challenging to have fine cross across the rank, at circumflex, we have downgraded to 1.25 burr. And we are ready to do the rotor now.
So, Dr. O'Neill, what do you think?
Going
of
1.25
that was
1.5?
pretty good, huh?
1.25.
Slick.
Yeah, that's fantastic. We use the.
It's talking about 1.5. I'll go with the 1 bar stage available.
So the question is the same. If fielder would not have crossed, what would be the next wire of choice? You know, there is pilot wire, which you can use because they have a little bit extra tip load, or miracle wires, which starts with a 3/0, 6/0. It's all what you're comfortable with. I called for a miracle ready only because with miracle you are able to make a curve and get into the circumflex. Now Gaia family, which has come with the Gaia next, which are very good wires, but they come with a pre-made curve and not easy to make an extra curve on those wires. And if you make an extra curve, it's not able to navigate well.
So Dr. O'Neill had a point to make. Dr. Kinney, 1 second. Dr. O'Neill?
I found the Turnpike LP probably the most crossable of the micro.
Why can't we hear it well?
We can't hear many of the people from the
podium. Guys, can you fix these mics? I don't know why they're not hearing it. They can hear me, but they're not hearing the panel, and that's not very helpful. So, yeah, so the Turnpike is what Turnpike LP is what Dr. O'Neill was talking about as one of the go-to. Okay, so let's see how you're going to do this. This is also could get stuck in the calcium, especially the 1.25 burr, right? So let's see.
A little more new. Yeah. And you know that one of the reasons for impala here is also is that very high chance of perforation in this case. Very high chance. So at least will allow us to do a work, gutter, and so forth.
Speed it up a little bit.
So that's why we said that it may be, some people may feel impala may be a little overkill, but just to make a procedure a little safer.
There's some problem.
Yeah, but that's okay. Yeah.
Oh, they're going.
So a little high EDP also, but more important. Yeah.
So sound sounds a little.
This is a crucial point.
We hear the screeches of the machine slowing down with this spur.
Yeah.
Change the wire position too is important.
What Nitin is saying, he's changing the wire position.
Yeah, just to
So
make
if you
it
see
not
here, I
be
don't know if
so
you can see
curved.
my hands. Yeah, you have a circumflex with the wire like this, and we are going with the rotor bar. You see here, this angle that we have created can cut the rotor wire. So what he's trying to do, if you see here, brake release, and he's trying to move the rotor wire a little bit forward, backward.
Changing the position that stresses.
Any question should we have
Right.
used?
To de-stress the
The angle, basically that wire bias on one side so that it is not cutting the wire. Yeah. Which has happened, and of course the bar is stuck.
Yep. We see that it went through.
Yeah. Actually, some of the tough cases, I'm working with the Boston Scientific to make even a 1/0 bar. I think in this kind of case, even 1.25 may be too big. But you need that. And then of course you can always upgrade it.
Okay.
Breather for the patient and breather for the operator.
Yeah, for sure. These are really, you're really happy that you have the impella in place, guys. I don't know that anyone is questioning that choice. Anyone on the panel would do this without support? There is a Peyton Lima.
I think I don't want to go there.
No one.
The LV function is
Might have to
increased, right?
proximal a little more, I think, here. I just
No,
pulled
it's
it.
okay.
LV is about 40 to 45%, but he presented with heart failure. So diastolic dysfunction. Today also the EDP was 24. So it does have a component, both systolic and diastolic, but truly it's not a classical over 35% EF.
Okay, ready?
Yep.
But I will say that if once available, and this is precisely, this Impala is approved for this kind of a protection. So two things. One, complication, and secondly, in a long calcific lesion, decrease the slow flow. So that is the key. It will decrease the overall chance of slow flow in this very complex case.
Okay.
I've got to say that I don't really like the
All right.
125 per. If you take a look at the angle, it's a very shallow angle. The 1.5 has a steep.
Kind of the LPL.
It actually cuts better. I think the 125 doesn't really cut very well.
Now use 1.5.
Hardly ever
Now
use
1.5.
Is there we got to redirect the wire.
And it's very easy to trap
It's
inside
okay,
the
leave it,
bird.
leave it. I haven't done anything.
Have the-
Okay, 1.5 bar, you want? Assist? It was
Right.
not easy.
Stepping
go
up
down.
to the next
I'm a little
level.
worried
What do
about
you
the-
think, guys?
Tortuosity to me, I think.
Think you go.
It's already we have,
1.5.
see that? The vessel is opened up, cut.
Okay.
There's a clear
I think
gutter.
we will just balloon.
The question is, the bar wise, you're done 1.25. Do you upgrade it, or you try to see your balloon can open up the lesion, then you don't need to upgrade it? I think that's reasonable. That's what Anu is feeling, that let's put a wire, let's put your balloon, and if it doesn't expand, you have a rotor wire there, you upgrade to 1.5. I don't think we will go to 1.75 here. Just maybe 1.5.
Roxana, can you see the proximal circ wire bias and looks
Yeah,
like
no,
you
of
have done a
course, we
good
see
job
it
with the
very
1.25
well. I mean,
wire. Yeah.
there's a lot of wire
Yeah,
bias.
So that's why I'm.
You're
I
not
don't
too
want to
happy
go with
about
1.5.
going. I mean, it's good if you could get away with the balloon, that would be great. But I don't know
Yeah.
how much ablation you got done with that small burr. So I think that's the question.
But remember, very important, what I say in the angulated lesion, and this question comes up all the time. You may not have done the ablation, which is point you are making. The key is, but if you cut the interelastic lamina, so you have really had disrupted the architecture of the vessel. So goal is your balloon should expand it. You're right. We have not done much in the ablation, but we have cut because of eccentricity, the interelastic lamina. So that as long as your balloon expands, your mission accomplished, kind of that now your stent will expand. So that's the reason you're right. If we just go by the principle of the debulking or the plaque modification, this is not the right approach. Now many people are very much against 1.25 bar. I can tell you. One of the reasons they say it gets stuck and so. Again, we probably do the highest number of rotablation in the world, about 60 per month. Our bar, if ever stuck, it was never 1.25. Either 1.5 or above in unexpanded stent or otherwise. So key is, as long as you did the technique what Anu did, slow movement, advancement, and so we have never stuck in. Yeah, I know a lot of people. This is a common. I would not say common myth, because there have been some cases people have spoken that 1.25 bar is traps the most, bar is stuck, and so. But I think it may be just a little bit a technique point of view also. So because I can tell you the data at our own Sinai, we do have some bar stuck, but if you take 1.25 or 1.5 or 1.75, 80% was 1.5. About 15, 16 or 18% will be 1.75. 1 or 2% will be 1.25.
See, I think the other thing to consider is doing a shockwave right now, because you've created a pilot channel already. And I think if you put a shockwave in, then you can go directly to stenting and have full expansion.
But only, Bill, you will require multiple shockwave here. Very long lesion. But yeah, that's a very good strategy. Rather than going to the second bar, and that is what we are going to do. We have written very calcific lesion algorithms 3 times already, and now getting some more experience with the shockwave, we are going to show, we are going to put it down that what is the best strategy, where the shockwave should be used, and so IVL in combination or alone. And basically, yes, rather than going to the second bar, using a shockwave is absolutely great choice.
Yeah, that would have been an interesting next step, but it looks like you didn't need it. I mean, the balloon seems
Look at
nice.
the balloon expanded with a 1.25 bar.
Yeah, it's amazing.
And this is the example we say, leave the rotor wire there. So if you need to upgrade the bar, you are not worried about.
I think we have to go with the shorter vessel.
No, but first open the ostium a little more.
We also burred into the distal circuit.
Yeah. Just open this way first. Yeah, just to high pressure. And then you're going to decrease the profile of this balloon in the guide. Let's bring back the guide. So what happened is, where you want to rewrap the balloon, come in the guide, go up high pressure. So what happened is, in the guide, you go high pressure. So basically, now your blood pressure will become flat. Negative. So basically, you are done what company does. Remember, all balloons come with the additional attachment.
2512 balloon.
Okay.
I think we didn't rota in there.
But point is your wire. Your wire, we have not done the work
The
in that.
wire is not in the same
Into the
plane
OM.
as the other wire,
Yeah,
so
that's
it's
what I'm
it's
saying.
possible that you're
Yeah,
because you
see that
rotated
OM,
down the
Austrian
other
OM is
branch.
little involved. Yeah.
You rotated in the other branch, so
Into the distal surf. We
Yeah.
went into the
This is
distal
sir. Yeah.
surf.
So we are going to use a 2.5 new balloon.
12 short. Yeah.
2.5 12. Okay.
very nice.
You want to see the
So
picture
will
yet
you
or no?
image
Not yet,
this,
not yet.
Dr.
I want to
Kinney,
balloon
at
everything.
the end? Will you do IVUS
No.
at the end?
No.
Okay.
Yeah, okay. No. We can do this case easily come out. Okay, let's go here. Despite
Yeah.
1.25 balloon.
Yeah, we need to go back to that.
Have a compliant balloon.
Compliant.
Okay, now
Get a 2 compliant balloon.
212 compliant.
do you want to do that or go with the guideliner?
No, 2
Godzilla.
compliant. 2
Okay.
compliant balloon. We are going to go with a 2 compliant balloon.
So we're hearing, you can go to the guideliner too, to extend
Yep,
the guide and help
yeah.
deliver that
Bigger picture
balloon,
now.
but
Yeah.
they feel like with a non-compliant, they can get to it.
2 or 12?
Well,
Or you can
ostium,
just-
that OM, there was a disease also.
Yeah,
if you
I
take
think so.
not
And
in
we
the
never
OM.
rotoed down there,
No, I
You
mean
rotoed the
OM,
other way.
It's in that LPL now. No, my wire is in the LPL now, not in
Yeah.
OM.
Yeah,
And with the rotabur, we did go distal to the OM.
But not to.
One.
Yeah.
Huh?
Well, that was from the 406.
Okay. So we're going to the LPL.
If this doesn't cross, then we're gonna have to rewire with the.
Hmm.
Yeah.
An LPL lesion.
Okay. Godzilla.
Yeah.
Okay. Let's get the Godzilla. Do you take one wire out anyway then?
We can leave too. Okay, go up here.
I think it'll be able to
Yeah, now
nose
it
through
will
there.
go.
Yeah.
Yeah, down. Okay, go up there.
My question is, what
No.
if you direct back your wire into the main distal circumflex
I tried,
and
would
then
not
try?
go.
Eh?
I tried, initially did not go. I had to
Okay.
maybe change the.
Got it?
Okay, let's start. Me try now.
Okay,
Get
so-
the Godzilla ready.
Take it.
You can do it on both wires still here.
Yeah.
Now, actually, the Roxana asked me, and this is for our audience, that we are not doing FFR, IFR in these cases. But these cases are so long subtotal.
Sorry.
Many of these wires will not be able to advance. But yeah, in a moderate lesion, and that is what the part of, is the whole case of the theme of the symposium. Our cases are so complex, these, if before making a decision, maybe to the branch or something that you may decide. But these cases, yeah, good. Wire went in now.
Give me.
Yeah. So key is that not appropriate, but we want to do some. Just take,
No, of course not in
overall-
those significant lesions, but also I think the role of imaging, we find so much more when we do image, but you guys are, everybody has their practice and everyone is very respectful of the great results you all have, but we wanted to make sure we mentioned the role of imaging and guiding intervention. And we will do that, I'm sure, when it's indicated FFR, IFR. So now you put the wire into the exact place where you did
Yeah, where it was supposed to be. Yeah. So now balloon will go.
Now
Yeah.
balloon
And
should
the other
go.
question is remove the rotor wire out. And the second question is just to say that FFR imaging. We do physiological IFR and FFR makes about 62% of our intervention. So the national number is about 32 now. And we are 62%. So that is one of the quality parameter which we have in our lab.
So the
And,
audience
I give
is
the report,
asking,
to
Dr.
all
Sharma, I have
questions.
the questions from the audience.
Oh,
They're
high
asking
pressure?
if there's no dissection, why would you not go to a larger burr to do better ablation? I think it's a good question.
No, there is
no.
We showed you from the
But
first time.
But there is a
already
little
there was-
dissection.
yeah,
There is a dissection.
And there's wire bias with the dissection. When you already have a wire bias, and then you want to go to a bigger burn, then there's risk of perforation.
And let's know what the audience they ask you. Let's see. Maybe
No,
it
I
was a
think,
virtual versus what? We can just
try
show
to
1
show
second.
you.
Here. Yeah, here. See that? Exactly where it
There
originates.
is
See, there is
definitely a
gutter
dissection there. I
created. Yeah.
wouldn't do that.
Yeah,
Exactly.
approximately. Yeah.
Gutter, yes.
Okay.
The patient characteristics too, extreme elderly,
We
someone
are ready with the 1.5 burr.
Yeah.
indefinite.
And here you are now with both the guideliner and
That's the problem.
the
Yes.
wire in
Okay,
the
go
right
up.
position.
What balloon is that now?
This
This
side.
is compliant again.
Okay.
Go up.
Go.
Maybe
Okay,
you
go
could
up.
roto past
Once they
the
dilate, then we
dissection.
go to other room. Yeah. Yeah, that's another thing. Yeah, no, that's okay. A lot of people have done. This is a 6-strength guy. You know, the rota wire will not go.
Oh, now here you
I
go.
mean, the bar will
It
not go
went
to
through
6
now.
Yeah, went in now.
Again,
We
on
may,
the
we
AV
may,
circle.
not even that, we may rupture.
Yeah. On 12. On a Sinian or
So
It seems like that needed a little bit of atherotomy as well.
Yeah.
No, the way you get the balloon down is you dilate in the proximal vessel, and then you get your Godzilla down there. And once you have your Godzilla in the proximal vessel, you can go distal. Now it's going good. Now you want to go 3-0 high pressure everywhere, up and down.
So I think
You
in
know, you
this
really
case,
open.
if you're okay, we can just see the picture, show it. If it looks good, we
Yeah,
can
if
go
you
to
show
room,
us, we
see
can
where
go
Mehran
back
is
to the
ready.
other room to see how you did, and maybe to the third case, because we only
No,
have
that one
11
is simple.
minutes.
This is
Our
done.
case, yeah. No, I know. We'll finish it that way. My case was simple. We dilated with a 4-0. Fantastic. It's like lumen, probably 9 millimeters square.
Excellent. Yeah, this is
It's
a
a
much
gutter, that's
larger
okay.
dissection now, so you'll be
I think
covering
you need to put a
this.
stand there.
Yeah, you'll need
Just put a
long
stent.
Yeah, this
I
stand
know
now.
high pressure.
No, right now stand.
Okay, good. Now we are going to cover the OM.
Yep. Right now.
So we will start 3-0.
Okay.
What stent do you want? 3-0-38?
Yeah. 338 Zion.
do you want to stent into the LPL or the
Zion,
No,
sir.
we're not touching.
Okay. We're gonna
After the OM, wherever we dilated, from there, come up to the left
gotcha.
main.
Okay.
Yeah, it's a pretty big dissection. So, okay, so we're gonna go to
Yeah,
your other room, Dr.
338
Sharma.
Zion to
What are we
Sky
doing?
Point. No, but I think we want this stand to be there and then we go.
Okay,
But I
we'll
think,
see.
Roxana, one important point, I think, in this
ready.
case is that why we did not go to a larger bar. I
Yeah,
hope we made that very clear.
Yeah, I think
Once we
you know
did
we saw
1.25
your
bar.
dissection, but then the other question was when the balloon wasn't going, could you have come in with the rotor burr past the dissection and just do a little bit of a distal ablation for but it looks like you were able to finally open it with the balloon, and now you're going to stent it and it should come out okay. I think that was
But
the
those
other
are
question.
all valid points. I know that is exactly the point we need to do and show. And I'm so sorry that we got a little distracted, abbreviated our cases this morning. And again, we learned from all this. And that is what Anu always wanted, do only 2 cases per hour. So next year, we are going to change. Roxana will just make 2 cases rather than 3. Because
I
we
agree.
need to go through this step by step.
Yeah, I think
These
everyone
techniques
wants
are
the
one
step
people
by
need to
step.
know. Yeah, exactly. And they want to see the case in entirety. That is the key.
Yeah, watching this struggle.
So we just have 2 cases. Yeah.
So,
Which is
next
okay.
step, Antonio. What you're happy with this? With this, you see the guideliner. What would you have done? Anything different?
Okay, now what I would have done?
She's
No,
still
I
having
think
a hard time.
I think
2.5
so
high
far
pressure,
I would
yeah.
have done the same. As was mentioned, maybe after the 1.5, 1.25, I almost always go with a
Yeah, you don't need
1.5.
that.
But the result is
Yeah.
good.
high pressure.
I think in this lesion, the dissection is expected.
Yeah,
Substantial.
It's a big dissection, but it's not a malignant.
not a big deal.
No, it's okay.
I don't know. I don't think I would have gone up to bigger burr. I think the artery was so angulated and tortuous that you might have really kind of filleted through it and caused a massive perf. So
Yeah.
I think they made the right decision to
it's the
stop
problem.
with the smaller burr.
Sorry,
I would have started with a 1.5 to begin, but I don't think I would have upsized after you created that huge dissection.
Would you ask them to go to a larger balloon now to do a little bit of a better dilatation? They're having some difficulty delivering the stent.
No, but that's exactly being done now. That's what the balloon they are doing it now. Absolutely, Roxana.
Can the Godzilla go a
What
little
balloon
bit
is
deeper?
inside?
That's the same.
The
Dr.
Godzilla,
Kwan?
can it
It's a
go a little bit
2.5.
deep? Can the Godzilla go a little bit deeper?
Oh yeah, she was putting it pretty
Yeah.
deep with
Yeah.
the Godzilla.
Yeah.
I saw that.
No, we'll go it now. More.
Come back a little bit.
So
Advance, yeah. That's
now,
it.
now deeper. That's it.
Let's do that spot there. You want to do that spot? Yeah.
No, we did it, no,
I have to get it come back a little bit with the.
Get the mouth.
balloon. Let's just do it while we're there. You can put it back in a second. Yeah.
I think we did. Again, I don't know. It's in a good spot.
Okay.
We'll never get it. Okay, get the stent again.
That's ready.
That's a
The
really
Godzilla
great
is
technique.
quite
Same.
down. Yes, go ahead, Dr. O'Neill.
Yeah,
go
that's
ahead.
a really great technique to use the balloon as an anchor, and you pull the Godzilla all the way down there, and then that way you can really get it deep throated into for the stent placement.
That's exactly, and I think she even dilated a little bit better.
Yep.
Okay.
And
So
same,
you see,
that once you
everybody
have your
could see-
Godzilla, make sure very little injection. Yeah.
Yeah, that's a
Everybody
really important
sees
point.
that the Godzilla is all the way down. You see it, the tip of it. It's really literally, as I'm showing you.
Can somebody show the
Hemodynamics.
hemodynamics?
Yeah.
Show
And
the
the
hemodynamics,
hemodynamics are
please.
totally
So just to
stable
say-
with
Yeah, but we'll have
What
this is the Godzilla.
the Godzilla, this is what it does. So you have to be very
Yeah.
fast. Deliver the stent, pull the Godzilla out so that you make sure then
And very
you
slow.
yeah,
confirm
we
the
see
position.
we see that.
How the Impala working well?
Yeah.
Yeah, Impala is good. I'm going to pull the Godzilla
The Impala
back
is
now.
working.
Impala is our
Godzilla
friend.
comes back.
Impala
Stent
is
is
our friend.
delivered.
Impala
Look at
is our
that.
friend.
And you see the blood pressure coming right up, right here.
Good,
Very
right?
long stent.
I think right there.
God.
Yeah.
Good,
Yeah.
go.
So all kinds of tools.
Now-
Now your guide is very deep. Yeah.
14.
You just brought it back.
No, I pulled back.
Back that.
Yep.
Yep.
This, what size
If
is
we
this?
if we need a short stent, this is a 3038.
Number
If we
325
need,
or
we will put
35
a 35 into the left main and then we'll post dilate the left main. Yeah.
I feel like this is a larger vessel than a 3.0.
Yeah.
I think you're going to post dilate with a
3.0,
larger
30.
balloon.
3030.
Maybe 3.5, yeah, we'll see.
Okay. You want to decide if you need a
Yeah,
stent?
let's take a
Okay,
picture.
ready?
Yeah, I need one. I don't know.
Okay.
The moment of truth.
Yeah.
All right.
Wow.
I think
Very
rest
good.
become a little
Excellent.
simpler. We'll be ready other side.
Well,
I'm,
we will put a 12 millimeter 3.5 coming into the left main, post dilate everything. Any questions for us before you go to
I still worry a little bit about the outflow of the stent. Anybody else feel good about this? Everybody feels good. I think it looks great. I mean, it's tremendous.
Step
Any-
down.
But
This is a step
we
down.
we are very reluctant to place these long stents. They restenose. If you look at these long stents after 3 or 4 years,
DEB is low. Yeah.
they always restenose.
Dr. Mehta?
Yeah, Roxana, I think
3512,
the
3512.
distal to the stent, I think will be all right. To me, the whole teaching part of this whole case was the use of impella. Look, the traditional thinking was EF is 40-45%, you could probably get away. But a lot of these maneuver, including the deep throating with the Godzilla as well as
Yeah.
the use of rotablator, I think the impella made it all
I
possible.
think it gives it a very clear-cut way. Dr. Nicholson, any comments from you?
No, I think it's very nicely done. A lot of nice techniques demonstrated. I think it's a great case. Congratulations.
Okay. So
Thank
what's-
you. You can go to
Looks
the.
like you're putting another stent. This one is a 12 or
Yeah,
15?
approximately we need another stent.
Okay, can we
Into the
see the
left.
fluoro, please, instead of thank you. Again, need the Godzilla. Still
Now,
need the
see that?
Godzilla.
Yeah, exactly. This is
It's
short,
amazing.
you hear me?
354.
Short?
Do you guys worry when the stent is there, you bring in
You
a
can come back,
Godzilla?
like 8,
Aren't
10
you
millimeters.
worried
You're
that like
completely
you
overwhelmed
could
right now. Yeah.
accordion the stent?
Sometime, right?
No?
Want to send it?
Yeah, well, the interesting point, Roxana, you
Yeah,
see,
sometimes it causes
I advanced
deformation.
It went very easily. If the Godzilla would not have gone easily, I will not push. Yes, there can be stent accordion, exactly what you mentioned. In that case, I have to go back with the balloon, distal to where
Dilate
it is,
better.
and then
Yeah.
over the balloon only I will, advance.
Yeah.
Okay? So now we are going to confirm.
Yeah, pull back
Yeah.
many millimeters.
Yeah. We are
6
too deep.
milliliters
This
back.
is going to look
Right?
great.
Okay.
Just do it
Come
on.
die. Good. Go.
Nice.
So we'll post dilate the proximal, I think, left main with 4O.
Yeah, I think you can use this balloon and
dilate
dilate a little bit down into that distal stent too.
Overlap with it.
I
Yes,
still think
yes,
you have
we'll do
room
that.
in the
Whatever you
proximal
put in
portion
the,
of that
whatever
other
you put in
stent.
the prox circ, put in the LPL. Those are the same.
Okay,
We
now
have
I
2
pull
minutes
back.
left. We're staying with you, Dr.
Prox circ,
Kinney.
LPL, exact same.
No, you have to go to other room.
Okay, because we only
Room
have 2
3, they're ready with
minutes.
OCT and
Let's go.
bifurcation.
61-year-old gentleman. He's diabetic, he's hypertensive, he's smoking, and the first stent was deployed in 2010 in the prox circ. There you see a trifurcation. Second stent was deployed in 2012, and the third stent in 2013. He did well until recently when he developed symptoms, and I'll show you what he has. Okay, now I'll show you. This is the LV gram is good.
Yeah.
The RCA has some disease in the proximal, it's not that bad.
Yeah.
And then we have this troublemaker down here. I have lost the distal circ before, and here, this is just AP projection showing the trouble. So we'll OCT first. Go ahead and show the OCT. Please, OCT.
And there are 3 layers of stents there.
Yeah.
Yeah, I
So you
can
guys
see
see the-
that you guys left those bifurcations. They didn't do anything to the side branches, but there's at least 2 layers of stent there, isn't there?
Yeah.
Yeah.
So there are 3 stents overlapping in the distal segment. So you see the right now you see the neointimal hyperplasia there,
1, 2, 3.
and then we start seeing the double layer. You guys see in there?
Yeah.
And then there is an area where you have a nodule, an ISR with a big nodule of neointimal hyperplasia. Just go proximal on this, and then you see the calcium. So over here is neoatherosclerosis, and that's calcium. See, the refrigency is very direct. You can see behind. So that's not lipid. If it was lipid, you wouldn't see anything behind. So here is a lot of calcium in this ISR. A 360-degree calcium there with the double layer, and more proximally you see neointima and a little bit more severe neointima hyperplasia. So we have trouble with this case.
Calcific ISR. Calcific ISR is what you're showing us.
Calcific ISR, exactly, in one single case.
And ISR for other question is, why not it's a calcific neoatherosclerosis?
Correct. That's what it is.
Yeah,
That's what it is.
neoatherosclerosis developed and now it's a very calcified.
That's exactly what it is.
That, as you know, multi-layer, we try to do, our goal will be to do IVBT. These are the cases we don't have drug-coated balloon, and we'll hear quote from Colombo. Look like Antonio loves the drug-coated balloon now. And maybe once it comes, quite a bit, but here we have only IVBT. So what we are doing now, bar
2.0.
It's a 2.0 bar, 7 French radial.
Yeah, 7 French radial.
If somebody wants to know that radial, we are putting a 7 French.
And it's a 2.0 burr, right? It's a large burr.
Yeah, 2.0 bar.
Yeah.
Give little
Give the atropine.
I think a question that needs to be explored is will drug-coated balloon work on calcific lesions? Because it's like putting a cream on a piece of stone.
Yeah.
I don't think the cream
You still
will be
have to do
absorbed.
atherotomy and then
All
put
right,
the balloon.
we're gonna restart now. We have a heart rate again.
Continue, yeah.
And the key here is not to do the strut, the rota strut.
Yeah, it'll take us some time.
This is a problem.
Yeah, don't get it
Too excited, yeah.
It will take some time. And see, I keep changing the wire position.
Yeah. And I see you don't have a pacemaker here.
We on first slide?
Yeah, good.
Yeah.
Yeah, so key is very simple. Radial, we try to avoid pacemaker. You give aminophylline 300 milligram and atropine 0.6 to 1 milligram. Pulse rate is good. We start with a 2.0, maybe a little more aggressive. We'll see few seconds, 2 more runs. Not, we'll downsize to 1.75.
I think aminophylline is excellent. We stop using pacemaker.
Oh, you're using
Aminophylline infusion.
All right.
Excellent. We stop having perforations of the right ventricle.
Okay.
Yeah.
But what I'm seeing is you have to be patient here because there's calcium, it's a lot of disease. You see some decel, you want to go slow and steady, which is what they're doing.
Why 2-0 burp in the beginning? You don't. Can we do a 1-5 burp and upsize?
Yeah, I think that's what Dr. Sharma was talking about. Maybe 175 and then go to a 225 or 2-0. But
yeah, because human was so good. That was the only lesion. Yeah. Yeah. Good. Good.
Yeah, we're done.
Okay, done.
Okay.
Now what wire and this? And we have the IVBT team.
Now we're gonna call the IVBT team.
No, they're here.
So Ron Waxman is here. I'd love to get him at the at the mic, Ron. IVBT, it's you are using it in your center. What do you think here? I mean, you wouldn't put in another layer. We don't have drug-coated balloons.
Why?
Can we open Dr. Waxman's Ron Waxman's microphone, please? Is it working?
1, 2, 3.
Yeah,
No,
no.
it does. No, we think that one layer of ISR is enough. Brachytherapy is still going to save you another stent and probably will get you the best result. So I think that all those cases that you showed today, even the underexpanded one, probably it's better to put brachytherapy instead of another stent. The other comment that I had, if you have 2 layers of stent, this is going to be much more difficult to open an underexpanded stent.
Yeah.
But brachytherapy to me, for DS restenosis is the first
So
line.
how many on this panel are using brachytherapy for these ISR cases until we get drug-coated balloons? Dr. O'Neill? Yes? And are you impressed with your results or?
It's too early to tell. I mean, the problem was that we've done it for 30 years, and the problem is 2 or 3 years, you'll get late effects that you're not aware of. But at least in the first couple of years, it seems to work.
Yeah. So Dr. Colombo doesn't need it because he has drug-coated balloons.
We don't have brachytherapy in Europe.
Yeah, no brachytherapy in
It's not
Europe.
available.
Yeah,
Dr. Nicholson?
I think I would echo the sentiments that Dr. O'Neill said. I think early on it looks good, but worry about the late-term effects.
Yeah. All right.
Give me the fielder one.
So now here you are with the balloon, and you will be generous with the balloon, right? What size is this? 3.5?
One of the things the trouble we have with this case is that we always lose that distal circ. So if I balloon too fast, it's gonna go down, and so I need to wire the distal circ.
Yeah, distal circ. Remember what has happened? Patient had a few interventions before, and the distal circ is knocked out when you dilate the main vessel. So we have not done that yet, and now we are going to do wire into the distal circumflex.
Yep.
Yeah.
We still open?
Yeah, open.
It's still open, but it's on a thread.
Hanging by a thread. Yeah.
So strategy point of view, and I know that you need to start your the debate. If you want to do, I mean, we had just shown another case, and only question is if the audience wants to see IVPT, how would they see it? Yeah.
Let's just see how that goes, and then.
Okay.
Little test there.
Yeah. Will be very angulated.
We really don't want to lose too much time for lunch, and the exhibits, Dr. Sharma.
So I think that you start your debate.
Yeah,
that will be best way.
Yeah.
Before the debate,
Before
and we'll
we
show
go
you
to
the end of
lunch,
the
you show us what you did, and we'll put on the side where if you can put the fluoro on the side where the factoids are, then we're going to go to our debate. And we thank you all, guys, for being here. And thank you.